All right. And yeah, let's go ahead and have a recording in progress. That sounds good. Let me see if I got no other new attendees. All right. So let's go ahead and start off with, and there's nothing on the IAFC or IEFF you can report on at this point in time, Jim, you're thinking?
Just something interesting. We may have a change in the U.S. Fire Administrator coming up.
Okay, got it. All right.
So,
Yeah, that
and
makes sense. Yeah.
yeah, the new NERIS system is intended to help EMS and to strengthen what is done, as opposed to the NFIRS, the NFIR system that's been used for 50 years. And then, Paul, the other primary discussion item last week in their technology meeting was about drones and
Okay.
the use of unmanned aircraft to improve medical care, disaster operations, wildfire, et cetera. So it's really impressive about the technology implementation in public safety that was part of that meeting.
Yeah,
Thank you.
yeah. Okay. Good, 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 good. Great to see. We'll talk later as well. Appreciate your help, and then also getting the word out about Ken's presentation later on. Okay, so let's go ahead and move on to Philadelphia. As usual, Crawford's just always on top of stuff. He's like, he's one of our canaries in the coal mine and can tell us what's going to be happening around the country. And so what's the latest now in the drug wars?
I don't know if you guys saw the Philadelphia Health Department report that Jim sent out a couple of days ago, but just kind of a little bit of context. Like some of the other cities around the country, Philly in the last year has been seeing an increased amount of medetomidine and its fentanyl. And the way the medics seem to recognize it is these are patients who appear to have overdosed, don't necessarily respond in Narcan, but at the same time, they're very altered and often very bradycardic with a normal blood pressure. And usually they get to the hospital, they metabolize whatever's in them, and then they get better. And a little bit more recent context, like other cities, xylazine for a couple of years now has been the predominant adulterant in our fentanyl. But with in the last year, and especially in the last month, that has actually changed to the point where medetomidine is more commonly found in our fentanyl than is xylazine. And so the way in the past few weeks, this has become more apparent in Philly is that patients who overdose aren't responding to kind of the normal routine treatments, Narcan, et cetera. And patients, when they're withdrawing, seem to be they have symptoms sort of like opioid withdrawal symptoms, but on steroids, to the point where some of these patients are profoundly hypertensive, profoundly tachycardic, diaphoretic, having severe diarrhea, severe vomiting, encephalopathic. In the pre-hospital setting, don't respond to much of anything. And I think probably the biggest impact now is on some of our emergency departments, like the Penn EDs in West Philly, Temple, and North Philly, certainly hospitals around Kensington. They're seeing these patients with severe withdrawal symptoms that are requiring massive doses of kind of the normal withdrawal stuff. So they get lots of methadone and Dilaudid, and they got clonidine and Zofran, phenobarb, ketamine, and ultimately some of them are being put on dexmedetomidine drips because the thought is they're actually not withdrawing from opioids. Now they're withdrawing not from xylazine, they're withdrawing from medetomidine. And a fair amount of these patients are ending up in intensive care units, and it's got sort of our smartest intensivists and toxicologists kind of scratching their heads about this and figuring out what to do. Currently, Penn at least has like an order set for opioid withdrawal. So like the docs can do sort of a checklist of what to give all these folks. And then we subsequently developed one for xylazine. And the health system's currently working on one for medetomidine as well. And I think you'll find in the next couple of months some publications coming out of Philly just describing some of the initial experiences with this stuff. And this is all sort of case series, case reports at this point. But the information was coming in from EMS, it was coming in from hospitals to the poison center and stuff like that, just trying to figure out what on earth is going on. But if you haven't already, you may start seeing this stuff as well. That's all I got.
Okay, that's all you got. So let me ask you this, is there a change in behavior protocols or in directives out to the paramedics about how they're dealing with it? Or is this just sort of after the fact we figure out what's going on?
It's kind of after the fact, and the problem is, I mean, at least in Pennsylvania, what they can do is relatively limited. And our drugs change so frequently that every time there's kind of a new twist on things, if we're to put out something, I mean, we put out sort of awareness information, but at the same time, from a protocol perspective, everything's state driven. So nothing is sort of nimble enough to be able to sort of keep up with this, nor are the pre-hospital tools really sufficient to kind of deal with this.
Yeah. And so let me, originally, I've always known that this is actually, everybody used to always talk about ketamine being a horse tranquilizer, but this drug is actually something that's typically used in veterinary medicine. Is that correct?
Yep, just like xylazine.
Okay, got it. And is it easy to get, or why is this ending up being something that's being used? Do you have any thoughts about that?
No clue. It's all business driven. I mean, whatever works. I have no idea.
Yeah. Okay. Got it. Okay. Now, has anybody else seen it? I remember last time when we talked about xylazine, Angus, for example, you'd been seeing it as well. Are you seeing any of this? And anybody else seeing any of this?
Oh yeah, we've got all that stuff.
It just depends on the day of the week.
That's not even our flavor of the week. Our flavor of the week is pink cocaine / 2C.
Okay. What's it called?
It's called pink cocaine or 2C.
2C. Okay, got it. All right.
TUCI, which is a sort of Spanish association of the two substituent groups that are on this particular molecule, but it's commonly known as pink cocaine. It's a couple different theories is where it started. Somebody said when a drug lab is about to get raided, they sort of sweep their arm across the table and combine everything into one big mixture. And then put a little pink dye in it to market it. But it basically has some combination of sympathomimetic along with hallucinogen. So it's sort of a MDMA plus cocaine kind of a thing, but the mixture is very irregular. What we're seeing with it is prolonged sympathomimetic toxicity, including up to cardiovascular collapse, along with sort of additional hallucinogenic type things. It's super fun. It's not easy to control. They tend to wax and wane. And if you do get one with that, I encourage you to have them monitored in a high level of care for a prolonged period of time.
Hey, John Jew was asking, what is pink cocaine? Is why it got that name, or is it just a cutesy name?
They're actually putting pink coloring in it. The thought is that it's part of a marketing strategy.
Yeah.
So it's sold according to our local toxicologists and our local fusion group that we actually just did yesterday, where we bring together a cross-discipline group of law enforcement, tox, poison center, EMS, et cetera. According to our discussion yesterday, it's actually somewhere in between meth and coke, and it's kind of in terms of expense, and it's kind of marketed as like a party kind of a drug. So we're seeing it primarily in a younger crowd. You can find a good page about it on the DEA website that gives some detail.
Interesting. Mick was asking.
Breaking Bad taught us that coloring the drugs is effective, right? It's a great marketing tool.
Absolutely.
Okay. Well, thanks for the call for remarks. The Mick is asking though, how long is monitoring, quote unquote? How long does that go on for? And is there any bedside test for any of this stuff?
Yeah, your tox screen is going to be really unreliable in this, depending on what kind of opioid is in it. You'll likely pop positive for some kind of stimulant, either cocaine or methamphetamine. But I wouldn't put much stock in your bedside UDS type stuff. I've had 2 patients in my ER with it so far. One of whom required overnight in the ICU because of the level of sympathetic overstimulation that was bordering on setting him up for cardiovascular collapse.
Got it. Okay. And Joe, we were making a comment about pink cocaine yourself.
No, just filling in some additional information that Angus was already talking about. Just
okay. Got
put
it.
in the chat there.
All righty. Got it. Okay. Thank you then. So, and have you been seeing it there?
No, we have not had much of it at all. As a matter of fact, we're still heroin heavy.
Okay. Got it. Oh, that's
Sorry, the other thing to say about it, Paul, is it's kind of a cathinone type thing. So think back to like bath salts kind of stuff. It can sometimes look kind of very similar to that.
yeah. Okay, got it. Hey, one more thing, I guess. When Crawford, you were saying they're appearing with an okay blood pressure and a low heart rate, which you might think has something to do with respiratory depression, whatever, that kind of thing, or
Mhm.
is it a direct effect? Do we think it's a direct cardiac effect, or is it a
It,
secondary?
it, I don't know. It may be, and that's once again, it's sort of an anecdotal thing, but it was a fairly consistent finding that the pre-hospital folks have noticed, as well as in emergency departments.
Okay, and that's across the board, or do you think related to this new drug?
Well, no. I think that's purely related to the medetomidine, but then the symptoms, the most recent symptoms, are from people withdrawing from the medetomidine.
Right,
Yeah.
right. I'm gonna look into what I will do is I'll try to talk to some of my toxicology folks and others this week and find out a little bit about that. So that's an interesting in itself is an interesting finding and to report to us. So we'll if that's a consistent finding you're seeing there, we'll be looking for it. And I'm gonna try to find out what the mechanism is in the meantime. Or if you can as well, that would be great. We'll see if we come up with the same conclusion. So
Yeah, our poison center is all over this stuff.
all right, good. We'll see what you can find out then for us.
Okay.
That would be really good. All right. Anybody else have anything else to add to that? The ODs of the week, etc. club. All right. All right. So then let's move on. And then most of you know about the results here because we've been telling you about it for about the last 5 or 6 years. But this has to do with status epilepticus that is resistant to benzos. I mean, if you look at it, benzos are very effective and they've worked over the years. But even when you went to the Rampart trial where they gave midazolam, like a 10 milligram dose, over 25% of the patients still were seizing away, which was a large number in that particular study. And those are high performing EMS systems that the NIH had selected to do this. They were trained specifically for this. And so that tells us it's a high rate of failure. So that's okay because it's really not that frequent in some respects. Okay, for example, if you have a system that has 1 million population, you might see one case like that per month. It's a low frequency, but here's the whole point: is that when it does happen, it is a major cluster. I mean, because you've got someone who's your only default option is to kind of scoop and run. And then, and then you're trying to scoop and run down a, twisting stairwell or just out of some cramped place, or even just transporting in the back of the unit, someone who's actively convulsing away. Hard to treat, number one. And number two, it's risky business. There have been lawsuits that have happened when people got injured as they're being transported in, but else we do. And then stressing it even further is you got family members looking out, or even the public at large sometimes, and it's just a very stressful situation. So the cool part was I remember about 10 years ago, just as Chris is Mr. Troperidol, Ken Sheppy was Mr. Ketamine, or Dr. Ketamine, I'm sorry. And he made a proposal, and it was interesting because he was able to cite some basic science literature that was coming up. And I think that's what's one of the coolest part about this, is that the basic science literature showed that as seizures progress and continue on, you get down-regulation of the GABA receptor sites that where cocaine, not only where the benzos work, but also where Keppra works, several of the other drugs, phosphopentone. Let's see what else. Even phenobarbital. So and the point was that just adding more benzos maybe just will be futile, and you'll just have respiratory depression coming on as a result. So one thing he cited was in the literature also was that there seems to be a progressive upregulation, meaning they're more apt to work, of NMDA receptors, and that's where ketamine works. So he had suggested, let's go on and try ketamine. And so it started a study that he was following, and I just want to jump ahead a little bit. After he got his first 20 patients, he did it as a sort of an abstract at the Society for Critical Care Medicine back in 2020. And it ended up receiving the Star Research Achievement Award in the neurocritical care arena because it was a breakthrough, and everybody really thought this was pretty cool. And so, in any event, we decided we got to continue on and get something in a statistically significant realm. And I'm going to tell you, He did it. So with that, I want to make sure get the person who came up with this concept and got us all, many of us already starting on this, and give us the latest results. Your article was published in Critical Care Explorations, Ken, I think, last Friday. And one thing I got to say about that, one of the choices for that is because we could get the word out right on this with this group out to 250,000 paramedics, or people covering a third of the U.S. population in EMS. I think this is going to be applicable to the emergency department as well. And I'll have maybe Chris and Jeff, comment on that later on. But also, we thought worldwide, the people who really do EMS in most countries are critical care. So we did an open access thing in Critical Care Exploration. That's their open access journal, and wanted to see how this turned out. So it says here, the effectiveness, it's an observational study. Ken, can you tell me what you observed? And welcome, and then congratulations. This is fantastic.
Yeah, thanks for the lead in, Paul. I appreciate that. And certainly I appreciate all your help getting this thing off the ground. So this all began, maybe 8 years ago or so, maybe a little longer. One of my EMS captains called me because they had a status epilepticus case that they had maxed out on benzos for, and they still had a good 10-15 minute drive to the hospital. And they asked me what should they do, and we have limited options in the field, as you pointed out. And I remember reading the basic science behind ketamine that you just described. So I said, well, what the heck, let's give it a shot. And they asked what dose, and I literally just made it up on the spot. Let's just try 100 milligrams, and sure enough, it worked. So just like you said, Paul, we all know benzos is the way to go, right? Benzos are going to handle good 80% or more of these seizures. A lot of seizures go away on their own as well. The problem is, if it doesn't work, what are you going to do? It's a really big problem. We know it actually causes significant morbidity and mortality in adults. And that's where the basic science really came in, which, GABA receptors go down the longer the seizure is going on, and NMDA receptors go up the longer they are. So the GABA receptor, that's the off switch. So anything that stimulates GABA puts the brain to sleep. NMDA is an excitatory. So anything that stimulates the NMDA makes the brain more hyperactive. But ketamine blocks NMDA. So my theory was, if you block the on switch, that's as good as an off switch. So that's why we tried it. So unfortunately, when you look at most of our common seizure medications and secondary line seizure medications, they all work at the same spot. So, definition of insanity is keep going with what's not working. And, again, my personal bias, which you guys have seen this before, is, ketamine works for everything. We know droperidol is a good drug, Chris Caldwell. We know. It's just not as good as ketamine, doesn't have as much a range of things it does. Ketamine literally does everything. So
you can't make a provocative comment like that and not sort of response.
Hey, you no comments from the crowd until after this is over.
Especially you West Coasters.
Yeah. So the big thing I noticed years ago that ketamine actually was anti-seizure. I actually spoke to a medical director through Eagle, someone that worked for the military, and they actually were using this in the military as anti-seizure. So I can't claim being the first ever. That's where I heard this. It's considered a fourth line drug for seizure, but it's really amazing what this medication does. And here's our protocol: 100 milligrams. This is after benzos fail, of course, or now whether we give the benzos or whether benzos are given before we get there. It's 100 milligrams of ketamine, and we do it as a drip. 50 cc bag of saline. We run it IV or IO. I'm going to tell you that when you give it either IV or IO, you don't even get the whole bag in before the convulsions stop. If you give it IM, it takes a little longer to stop, but it's a lot faster to give the IM. So actually the 911 to convulsion time, I'm not sure which is faster, because IM you can deliver so quick, but takes longer to onset of action. In children, we just do either intramuscular or intranasal, and we're going to talk about that. Maybe intramuscular might be the way to go. So how we do here, and those of you in Eagles last year, we did present some of this data. It's phenomenally successful, and we've since done another follow-up, with another year's worth of data, which shows it's still phenomenal. So for adults, and Paul and I actually talked about this because, while they're in the ambulance with you, while they're in the rescue with us, it was literally 100%. Successful. But we did have one case that had stopped convulsing with us, and had been like without a seizure for 20 minutes, but before we're at the ER, but before we officially turned over the case, the patient had another seizure. So I told him, listen, out of academic honesty, we're going to claim that as a failure because they ended up seizing, even though they had gone about 20 minutes without a seizure. So it's highly, highly successful in adults. Kids, we don't have as many kids. And it was not quite as successful in kids. I'm going to talk about a little bit about some of these numbers here, because we used it on protocol. By on protocol, I mean they got the benzos first and then ketamine. There were 15 uses, but when we actually dove into it, there's really 2 cases. They weren't actually seizures. One was a anoxic brain injury, and the other was having the classic postictal movements, and had already stopped seizing. But again, for the purpose of the statistics of the paper, that turned out to be 73%. If you take those 2 that aren't really seizures, it's actually closer to 85%. And then when you look at the failures, there were 2 what I call true failures. One, we gave the patient intranasal, which I wonder if that's less successful. I don't think we have enough numbers to give you a definitive answer on that. And the other one was really interesting because some of these cases, we've seen some of the cases we saw them on another status epilepticus, meaning we already ran them on a status epilepticus, and then we had a secondary status epilepticus. So that was one of these cases where we had taken care of this patient before, gave him ketamine and worked like a charm, and then some other date they had status again, and we tried the ketamine and it did not work the second time. So I'm not really sure what to make of that, but still highly successful. And then the main thing we want to look at, combining sedatives, you got to worry about all the airway stuff. And it turns out that we were able to get all the vital signs we're looking for in about 90% of the cases. As they're flopping around. It's hard to get that. But of the 90% that we were able to get the vitals on, the vitals got better after ketamine. I mean, we didn't really have any downside from giving ketamine. We didn't have to intubate anybody. We didn't have to breathe for anybody. If they were hypoxic, they were hypoxic before the ketamine, and the hypoxia got better after the ketamine. Same thing for the end-tidal CO2. So highly successful is really what we came out with. Our conclusions. I do suspect, and by the way, when you take the entire population, the children, the adolescents, and the adults all together, you're in the 94-95% overall success rate when you give ketamine. And we did have several cases that they never got benzos to begin with from us, either because they got benzos from a doctor's office, from a family member, and we went straight to ketamine. It worked in all of those cases as well. And there were some cases where we had 4 of them where they were, quote, benzo allergic, and I'm not really sure what that means. I don't know if anybody's truly allergic to benzos, where they got no benzos at all and went straight to ketamine as a first-line drug in those 4 cases, worked 100% of the time in those cases too. So I do think it's a very successful thing. It's something we carry on the trucks. I'm not saying it's the world's best second-line therapy when you've got a whole armamentarium in your pharmacy, but for a pre-hospital solution, I think this thing's got legs. So that's it. Thanks very much. Appreciate it.
No, it's great. And then what I really thought was really cool. We actually, I wanted to, I was hoping, I don't know if Charlie is on, Charlie Coyle, but or not, but he was, of course, instrumental in helping us get this whole thing started, the training in the first place years ago. But one person I really wanted to give a pat on the back to was Sebastian Garay, who is our person who does the data sifting and so on. And we drilled down on every single case to see if all this was absolutely true and to see what's happening, not just numbers, but we actually looked at the specific outcomes, like the case you told me about, the one woman who did seize later, it was in the hospital. The only reason why we probably added her in was because the paramedics put it in the chart that they saw it later. But during the whole pre-hospital phase, she had been seizing for a long time, got drugs from the facility that she was in. She was a chronically ill person and had sepsis and so on. And we kept her without seizures for next 20 minutes or so. And I think that was fascinating. We kept her, we protected the paramedics and the patient for that 20 minutes during that ride. So then that's the whole thing. I think this, there was, you may find out some pushback from this, but I look at it as protective because one, you have ongoing neurological damage if you keep season, number one, and in theory, at least presumably, you're helping to protect that. But we did protect the patients in terms of making it a safer transport, extrication and transport. And also, as you pointed out, about a third of these patients had respiratory aberrations, before the ketamine, because they were convulsing away and can't breathe very well. And I think everybody got, if not completely turned around, they were at least improving in most of these cases. And then the one case that you point out where she had anoxic posturing, that was one of the cases where it didn't normalize, but she was definitely better too as well. And she actually, whatever she was having was mitigated with this as well. Now, one thing I do want to bring up that's kind of an interesting thing is what I call barroom peer review. As I was making a presentation and at the Society of Critical Care Medicine last year, someone was calling me over and kind of congratulating me on it, and they thought it was pretty cool. And then they said, "What are you up to next?" And I mentioned this, and they said, "Okay, well, you stop the seizures, you stop the convulsions, the motor activity in every case. There may be a certain percentage of patients who may still have some electrographic seizures going on. But I think with the ketamine, and based on what we just said, I think it's going to end up being a very small percentage of cases. More importantly for us, it's just that it made things better for us during the pre-hospital stay. So I think this has been fantastic, Ken, what you did. I got to tell you, we have oh, go ahead, Peter, because I want to acknowledge a special guest in just a second. Peter, go ahead.
Thanks, Paul. First, I just wanted to congratulate Ken on coming up with this concept many, many years ago. That's how we first met, because he was a ketamine king back in Florida when the Flacca epidemic was going on, and he saved lots of lives back then. It kind of revolved into this big study, again, thanks to people like Chief Coyle, but then also you, Paul. You put many, many, many hours into this, and just a big thank you to you for making this the first publication on a topic that, if you look at Joel's comment on the side, it's going to change practice, not just pre-hospital, but in the hospital. I see ketamine being used there as well. And just to Joel's point, which is what I wanted to add on, early on, the hospitals thought we were absolutely nuts. I remember having to go in and kind of do the hospital rounds because they were up in arms. But then I took Ken's presentation, I put it on the PowerPoint, and they all left and like, wow, this is fascinating. So this paper, I think, is maybe not the final nail in the coffin, as was alluded to, and I'm sure other people will do studies on this, but surely this opens the doors, I think, for many people to do it. I know Jeff Goodlow has been doing it. Jeff Ziegler called me up, just the last story, because someone asked it too. He said that there's one family that they requested that when they call 911, please just go to the ketamine first. And so I do think that ketamine in certain cases, in certain kids, should be given because they're chronically ill, they're chronically on benzos. And when we get there, we probably ought to just go right to the ketamine instead of giving them more benzo and then buying a tube. So just that, congrats to everybody and great job.
So along those lines, let me ask, John Kramer asked, is it dependent on benzo? I think this is important in that we wrote it up as a rescue drug, okay, for this, that you go with benzos first, etc. But we've learned with some of these cases that they just weren't responsive. So in fact, we went directly to ketamine, as he pointed out, and it worked. And the rationale for me in that situation is I'm not still looking at it as a first line, but under these circumstances where there's been prolonged seizures, and we already know GABA downregulation is occurring, that you might have that you may be ripe for it, and it possibly could be. So I'm not saying you should go do that, but I think it's something to be explored. That it could be.
Yeah, just Paul, to your point. So just to expand on that. The standard of care is benzo first line. So that's how this was designed. But we had a handful of cases where they're, quote, benzo allergic or whatever, or they felt benzos wouldn't work for them. So we had a handful of cases where ketamine was the first line drug and worked in every single one of those. So that's not what we're advocating, though. We're advocating as a rescue drug, other than these poor patients that we have that they've had repeated episodes of status and they've actually asked us to go straight to ketamine because it works for them.
And I'm going to go to Nick, but hey, Tomas, I'm going to tell you, I'm going to be coming to you in a few minutes. So just so you're be aware of it. Nick, go ahead.
Thanks. I'm curious, Ken, can you speak to how many patients ended up getting it IV? Just thinking about, an actively seizing patient, and I'm curious why you guys chose the 60 drip set instead of the typical 10 drip set.
Okay, so let me ask the second one first. Since Charlie Coyle's on there and he's the brilliance behind the drip set things, but I also let me just shout out to Sebastian Garay, who actually helped, with all the number crunching of this stuff.
Yeah.
We wanted to get rid of all the clock method and the drops per second, all that business. Turns out that most drips you're either going to do wide open or you're going to do over 10 minutes. So when you do a quote slow IV push, you want to go in over 2 minutes. A 60 drop set wide open is 2 minutes. It doesn't matter what's in the 60 drop set. 50 cc, 60 drop set wide open, it's gonna run in 2 minutes. That's why we did that. When we want to go over 10 minutes, whatever you put in that same thing, a 10 drop set, it's going to take 10 minutes to go in. And that's literally, we don't have clock method or drops per second or any of that business. It's just, that's how we do it. So the 10 drop set, 1 drop a second is how you do it.
Yeah.
Let me pull up the supplemental stuff and I'll get you the answer on the other one.
Yeah, before you get to that, the majority of these got like, I don't know, 85% got IV, then another 10% IM. There was a few IOs and all that. Ken will pull up the exact numbers. But the what I was going to say, I think what was really interesting, because we actually, especially after we went through peer review, we actually went back and even talked and did interviews, Sebastian and I, with various people. And what we found was almost in every single case, they only got half of it in, and they were already stopping the convulsions. It was like fascinating, almost every case. So they only but we've our orders were complete the dose. You go through and got it all in. But I'm going to tell you, it was already stopped in half the cases before you even got the thing in. Because one of the questions came up to us was that how long did it take? And that's how long it took. It was striking. The other thing that gives us an advantage in the pre-hospital setting as well, I think even in the emergency department, is that these people are actively convulsing, so it's hard to get an IV or IO, whatever it may be. And this is a drug you can give IM. The IM onset was a minute or two more, but you got it on faster too, and some if you had to. So so with it, we were doing that. And then going back to the case that is that with the kids, we gave some IN, and one of the kids that didn't, he responded eventually, but slowly. He had actually, when I went back, he found out he had a low Versed dose. So that was one interesting aspect of that particular case. But Peter, tell us why. Oh, Peter has his hand up. But Peter, can you tell us why we don't give IV drips to kids? Okay, that was one of the part of our protocol. Okay.
Yeah. So this is something that we've kind of we finally figured out over time, and I think that our latest protocol is where it should be. But most agencies, Paul, as you know, carry the ketamine 100 milligrams per ml or the 505. If you're going to give 1 per kilo IV to a kid who's 10 kilos, and you start to think of what that volume looks like, you're looking at 0.1 ml. And then, it's hard to end up giving ketamine. I would never recommend giving the concentrated version of ketamine as an IV push, which effectively that's what you end up doing. You end up risking laryngospasm. You end up risking tenfold overdoses, which with ketamine is not that uncommon, because there are some people who have it says 0.05 ml. I mean, you find me someone who can get that right in the middle of the night when a kid's seizing. They're not going to do it. So what we decided to do was go 2 milligrams per kilo IM, now favoring the IM side of it, so that you get a higher volume. You don't have to worry about laryngospasm. You don't have to worry about how fast you're getting it in. And it mitigates this issue of these IN cases where you get some of the medication just kind of dribbling down the esophagus or just not getting in at all. So,
so just to that
that's
point,
why we landed where we are.
Ken was saying, I don't know, we should do further studies, but when you look at, there was one case in kids, there was one study done by one of our co-authors in a series of 6 kids, and all of them got an IV except for one who got an IM, but they all got parental doses and they all stopped in those cases right away. So what I think I'm leaning towards IM for sure in the kids and staying away from IN. I mean, from my point of view, that's just my personal thing, but that we'll probably put that in the protocol maybe as preferred route to go under those circumstances. And there's a lot of data with particularly with benzos already out there Yeah, that's right.
Yes.
It's there, right? So,
You remember we had that guy on from Chicago who basically
yes.
said that intranasal Versed, he wouldn't recommend it anymore based on his very large study. We had him on the Florida
Yeah.
webinar, and
Yeah.
he would say Versed IM instead of IN in kids, even though for many years I've had many good successes with intranasal Versed. But when you look at his data, it's pretty convincing that IM in kids is better than IN.
Just as an FYI, one of the limitations of the study is that we didn't have hospital follow-up, and we kind of had I wouldn't say informal, because there's a regulation, I'm sorry, in Palm Beach County where they have to give us follow-up on cases, but it's more of a gross follow-up. We don't have access to their records, etc. So we were able to get some of that information, but by and large, we didn't get it. So we didn't know if they had an EEG that showed there was ongoing seizure. We didn't know, did they die later on, or did they have seizures later on in the hospital? So that was one limitation. But if we had to do that, then we'd have to go to all those different hospital IRBs, like 12 different IRBs, and go through all those motions. It was just easier to say, hey, the biggest problem here is you got someone who's convulsing away, and it's kind of dangerous and risky to try to transport them. But what else did we have to do? And we wanted to know, how often did we control seizures during that whole period during the pre-hospital transport? And it was 100% in the adults and pretty close to that in the children. So that's it. I want to introduce you to somebody, by the way. I'm very proud to introduce you to, because he's one of the people I really admire a lot. And he was just he's an inheritor of this study because it was accepted before he came on as the editor-in-chief, but it's the editor-in-chief of that journal. And I gave you the rationale for why we wanted to go there. One is open access, that anybody can get this anytime, number one. And number two, that many people around the globe who do EMS are critical care specialists. We really want to get the word out to them. But also, I think, and I can have him comment it, I mean, this does have implications for for future study, let alone the fact maybe even future care in the hospital as well. So, Tomas, can you come on and join us from you're in the UK, right? Aren't you? Are you out in Wales, or I can't remember where you are located?
Yes, hi everybody, and thank you for the invite. I'm Thomas Zagmany. I'm a gasman by training, and in the very early days of my career back home in Hungary, I did do quite a bit of pre-hospital stuff, because the ambulance service in Hungary does have doctors on their special cars, and on their helicopters. So
Hey,
I
Tomas,
have.
hang on. Hey, AJ, you're live. AJ, turn you mute yourself, please. Thank you. All right, go ahead, Tomas.
Yeah. So I read this with interest, and mostly because I use ketamine quite a lot in my anesthetic practice.
Yeah.
But I haven't used it in with this indication. So when I read it as editor-in-chief of a journal, I thought that yes, it probably will change practice, and it is something that could be rolled out and could be looked at in other healthcare systems, because it is a drug which is quite ubiquitous around the world, and it could be looked at. So I'm very interested to hear what are your future plans with this one, and how can you monitor the use of ketamine in these circumstances, and how can we get the data out there in a safe and systematic manner?
Yeah. One of my responses to that, by the way, is that Ken brought it up in his talk. I just want to re-enhance it. Is that it is sometimes real difficult to just get a pulse ox on and keep it on. I don't even know if it's accurate half the time. And if anything, it's going to show you a desaturation or whatever, more likely than a good reading. And the end-tidal CO2 to some extent has some limitations. But we did our best to show it, and in general, it really looked like you were improving things overall. They were not in good shape. And then we never had to do any, as he said, no active intervention. We didn't have to breathe for somebody. We didn't have to give them IV fluids. There was just no active interventions, and everybody was doing well, to answer that question. But your point is well taken, and that everybody should continue to do this and do those same safety checks as you go along. And I think, yeah, you're right. Hey, one thing that you might find of interest, that when we first brought this in, it was, I had talked to at that time to Tim Buckman, and they said the numbers seem to be kind of lowish. But when I actually talked to our companions here, even people in large cities like Chicago yesterday, and they said, wow, how'd you get those numbers? I said, well, we did it over 7 years. So this is actually a large number for this kind of event, number one. And number two, when we made a comparison to the, we should have done it a priori, but we did it sort of retrospectively, and it's in the appendix. And that's the other thing. I'm going to pull up the appendix, Ken, and have everybody look at that. But what we found is that there they had 25% of their cases, which was roughly 91 of 342, who did not respond to the 10 milligrams of parenteral midazolam. And so when you did the comparison side by side with a Fisher Exact with our numbers, just the 56 over 57, remember from the pre-hospital point of view, this really was 57, but you can't do statistics that way. The p-value was from here to there and back again. This really was robust from that point of view. So it was kind of cool if you use that technology. I mean, it's just one piece of information. It's not necessarily proves it, that kind of thing. But I thought that was pretty cool. But I'm actually so glad that you're on as the chief and the editor-in-chief now. And I think I wanted people to be aware of the journal and they know that it's a great place to send some good material, because a lot of the folks on this call are data producers. So yeah, and just real quickly, I don't know if I've mentioned this to you. So this call is mostly centered around the doctors who are responsible for the 911 systems for the, I don't know how many largest cities in the United States, 50 to 60 largest cities. So they're responsible. I think Jim Augustine, who had to step off, told us once, for about a third of the U.S. population. So, and they have all the data because they're in the large cities, and like this, for example, this organization here that did this, Palm Beach County Fire Rescue, has roughly 1 million population that they handle there, and kept very busy. By the way, during that period of time, there was about 2,000 seizure responses, and of those, only 81 for this condition. But when it happens, boy, it is, when it happens, it's really traumatic. Put it that way. It's a high event. Ken, did you just pulled up the supplemental material? So when you get into the paper, it's up. Tomas, did you put a little thing in the chat? Did you put
I put the link in the chat. Yes.
Yeah. Okay. Gotta see how far back it is, or if you could redo it again, that would be really cool.
One second.
Yeah, I just put in the part that you were talking about there with the, looking at the Rampart study.
Yeah.
But yeah, the appendix itself is multiple pages long and gets into a little more of the details.
Yeah, about the yeah, and it goes to everything from demographics to the rationale for the
Our
study.
protocol, everything's in there. Yeah.
Yeah. Right, exactly right. So it's very cool. And then also we had tables regarding tables regarding the entitled CO2 or whatever, all the other issues that we had in there. But anyway, so that was really cool, and that's really great to have you on, sir. And you're welcome to join us anytime and see what the latest thing. Were you on before when we talked about the latest thing they're mixing in with fentanyl? I don't know if you heard that or not. Oops, sorry about that. All right. But anyways, there's always great topics, and this is, and it's very informal. As you can see, we like to tease each other, and it's a great group. It's really kind of cool because it's not on a committee of a bunch of pretentious doctors pretending they're smarter than you, right? These guys are just fantastic out to help each other and be advocates for each other, and I love working with them. So it's really, really good. So thank you for being on. And then tell us again, where are you today? Where are you based?
So I work in the UK, in Wales, and I live on the border of England and Wales.
Yeah, that's what I remembered. That's right. It's good. And how's your weather today? Just sunny and bright and warm?
It's it is cold, but it's not wet at the moment. So it will change, and it will be
my God.
more than wet.
It's reportable, right? So it's good. But it's really great. Tomas was fantastic to work with over the last couple of years for me. I was very, very pleased. A year ago, or well, more than that, a year and a half ago, he called me up and asked if I could do a plenary presentation for them at their society. There was like probably 5,000 people in the audience or something ridiculous like that. And it was really cool, and I was just very flattered to do a presentation for them, and I got to work with them. And I got to tell them a really funny story though. Is that so? He says, "Hey, while you're at it, can you do another, presentation? We're going to do a pro-con debate on ECMO in the field, right?" And he said, "Would you mind doing that?" I said, "No, that's fine. I can give you a talk on that. That's fine." So then he calls me back a week later, says, "The other guy wants to do the pro. Can you do the con?" And I go, "Sure, whatever you need." Right. And it worked out really great. That was a kind of a fun time. So I was just really pleased. So he was the head of this. Oh, the reason why he was the one that called me to do this was that he was the head of the program committee for them. And that's a tough job. I'm going to tell you how many, you had to sift through a lot of different, I guess, proposals coming. How many proposals for talks do you usually get, and abstracts and so on at the meeting?
So, well, I will give the plug now to 2026 then.
Okay.
You can still submit proposals for the SCCM 2026 Congress, and we usually receive around 550 to 670 proposals that we are whittling down to the 2.5-day program. So it's a fun job, and we get to work with good people like yourselves. So I'm looking forward to what is happening this year, and I'm more than happy to put the feelers out, because I know the future Congress co-chairs. So if you've got anything which is coming up, then let me know, and I will get you in touch with the right people.
Good. And I actually personally have some stuff, and I'll maybe send that to you. One thing I am going to be coming to Orlando this year, and I've been asked to present this paper there. So for those of us in Florida that want to come along, let me know. But that's it. So, all right. Anybody else want to add things? Jim, you're still on again. Do you want to talk about how many folks that we have on here?
Yes, I had something else cancel. 70 metro areas in the U.S., 106 million population, 161,000 providers. That's a wonderful group, as you mentioned.
Yeah, so that's great. And so that's the reason why I wanted to make sure the group got to meet the EIC here, because you guys have a lot of data and you're doing some really progressive things. And I think that this is really a good venue to put this in. All right. Well, listen, anybody else have anything to add to it? Ken, just congratulations. This is
Yeah, thanks, Paul. Just one quick thing. If Chris does come back, just point out that we had another study. We gave droperidol and didn't do anything except stop vomiting, and it was otherwise useless drug. So I just want to point that out. It's not worth writing up, so we're not going to bother writing it up.
Hey, Jeff Goodloe, Jeff Goodloe, who's just the immediate past chair of the board of directors at ACEP. Are you on with us still today, Jeff?
Yeah, you bet.
You got to review this, and I wanted to see if you had any anything other comments you would make, and/or anything along the lines in terms of the emergency department use of this versus the other things that you can carry there, such as a lot of time people give Keppra, that kind of thing. So what's your reaction to this? And as a way of introduction to our friend here, hey Jim, you might be live. Somebody's live there. Okay, just see, maybe Jim. But in any event, what I was going to say, Dr. Goodloe is not only a professor there at the University of Oklahoma, but he also is the medical director over both Tulsa, Oklahoma, and Oklahoma City as well. And is again, as I just pointed out, is a national leader in emergency department care, let alone pre-hospital care as well. So any response from you? I figured I'd pick on you since you're here to see. You've just heard this presentation. What do you think? You've read the article, if I remember correctly, right? So.
Yeah, and hey, I think we've got another professor or two in EM in Oklahoma now, which is great because the sauna and hot tub is not so lonely anymore. So, that's fantastic. Congrats on the grandkiddos, by the way.
Oh yeah, thanks.
And yeah, so I Ken et al. I mean, really, hats off to you. Great paper. I truly think that it can be practice changing. Peter, I think, mentioned this earlier. I recall, gosh, it's probably been 2 or 3 years ago. A lot of folks don't realize how much clinical ED work that I still do. I still work between 10 and 14 shifts a month and love it. And when I slow down, I will either have fully retired and none of you will ever see me again, or I'll be dead. But Until then, it's full throttle up. And so I love being in the ED. And had a status epilepticus case and real time called Peter, and I was like, hey, remind me that ketamine dosing thing again, because I need it right now. And so I think it's great. And I think it's not only great from obviously an EMS arena perspective, but from the ED as well. And I think because of some of the unfortunate political ramifications, if you will, of ketamine, I think that continues to hold up adoption and incorporation of ketamine in the field. But I certainly think, you know, there's a little bit more widespread use of ketamine and acceptance of it in the in-hospital setting, although still, you know, not ubiquitous. But I think this has a lot of impact for us in the emergency department setting as well. So, you know, hats off. It's wonderful to have, you know, another tool in the toolbox, and particularly one that works so well, right? So I'm never going to pretend to be as statistically elegant and sophisticated as Rimley and some of her cohorts.
Yeah.
But I don't think these numbers are just throwing, you know, ketamine and seizure stop and, you know, is there a real cause and effect there? There clearly is with these kind of numbers. And so
Okay, good.
fantastically done. Excited for where we go from
in
here.
fact, you mentioned Remley. Remley was going to try to get on. I put her down as the senior author on the paper. She did because she was constantly guiding us on the statistically. And it says, and there's this principle that if you have like something like 56 out of 57, or even, you know, or the 57 out of 57, it's perfect. You can't do statistics on it. And that's what's so interesting about this. And it was really cool. I want to, hey, Chief Coyle, if you don't mind, Charlie Coyle is the person that facilitates all this. He's the one that's the boss for Sebastian, who did all this amazing work that, you know, he was a great partner for me. And you know, and more importantly, he has a system with supervisors that oversaw these cases, and just great operationally made this all feasible. And most importantly, he gave better care to his patients as a result. So Charlie, I just wanted to come on and sort of recognize you, if you don't mind. So is that okay?
Yeah, no, thanks, Dr. Pepe. And I want to, you know, just start from the top and work my way down real quick. You know, Dr. Shepke brought this concept to us like in 2015.
Yeah.
And of course, we try and do adults and pediatrics. And anytime that we can do the same, we try and do the same. So, you know, thank you to Dr. Intevi and Dr. Shepke to bringing the concept forward. Dr. Pepe spent countless months analyzing the data, pulling the charts, calling the hospitals. You know, the paper came out excellent, and it's largely due to, you know, his time and effort on it. So thank you so much for getting that done. But I just want to add a couple little things that I heard on the conversation. Number one was the ketamine. The way that we carry ketamine was really because of, you know, we were giving it for IM injections for behavioral emergencies. So it's a very concentrated dose. It's 100 milligrams in 1 ml. So that's why we dilute it. That the question came up earlier. Why a 60 drop set? Because it's so potent that if we put it in a 50 cc bag and run it in with a 60 drop set, it'll go in roughly 2 to 3 minutes. The paper says that, but if you were to do that in your agency, that's the explanation why. Another thing that was interesting too is we had a couple of cases that actually had a letter from the neurologist at the home to go straight to ketamine. So some of the allergies that popped up, I ended up, you know, talking to some of the crews, and they just put an allergy down because they thought it was an allergy, but essentially it was the neurologist said, just listen, go to ketamine. Don't give my child this medication. And then the last thing is we had to re-educate our paramedics on a couple of cases, a 14-year-old and a 15-year-old. And the reason why we had to re-educate them is because, like Dr. Pepe said, they gave the drug and it worked so quickly, it stopped the seizure. But later on, the seizure picked back up at the hospital. So the re-education came for us is if you were going to give a dose, give the entire dose, even if the seizure stopped. So just be prepared if you implement this, when your crews start to see the seizure stop, they might stop the infusion, and ultimately it could lead to the patient having another seizure. But other than that, thank you for having me on, Dr. Pepe. Thank you for your hard work. You know, Dr. Shepke, congratulations. And we're looking forward to doing something new and different and studying some more. So thank you so much to the entire team.
Good. It was profound, you know, as I interviewed the different paramedics, how they said, oh yeah, probably I only got half of it in and they stopped convulsing, at that point in time. So you hear me using the word convulsing because of that thing that that actually one of the neurocritical care people, there's a whole group of neurocritical care people sitting around a table at a bar, and they invited me to have a drink, and they made that point, and that became an important part of the paper. So I really like barroom peer review from going on forward. Just want you to know that, Tomas, okay? Which is great. All right, well, listen, let's go around the room real quickly and see if what else is going on, if anybody else. Oh, one thing, any other questions or any other comments about this one here before I start going into some other topics that I wanted to cover? Charlie, thanks again for coming on and being here with us. And I wish Sebastian was on. I wanted to maybe even get him on next week or something, but I just wanted to say, I can't tell you how hard that person worked, and a lot of it is on his own time and despite other tasks that he had. So thank you for giving them to me, because we unfortunately had to go through a lot of stuff because of some of the peer review processes that went on that probably were unnecessary, to be very blunt, but we did it, and actually we learned a lot more as we got through it. And so there's so much nuances to all this. So one of the persons that, for example, and this is what we did, is we try to provide this as a real-time study, meaning real-time what the experience of the paramedics were. So if the paramedics may have stopped the convulsion, but the person still had abnormal motor activity, we would say, oh, that didn't work, okay? And because it probably maybe not, it's from their point of view, we didn't stop everything. But as we find out later, that was actually for that particular syndrome, that person, that was actually a post-ictal state. And so to be able to drill down and get that follow-up is an important part. So if any of you want to do these studies, please do it. One other thing that someone asked me about last week, which I thought was pretty interesting, was because people are seizing this long, are they having rhabdomyolysis? And I went, so that may be another thing to follow up on in future studies as well. So something to think about as we go along here. Okay, anything else? If not, hey, someone asked me a question about if anybody has any models, and maybe I'll put out a survey on this, but this is about like with our increasing homeless cases, are anybody using police and social workers, or actually cross-training police officers or law enforcement who can actually bring people in or make dispositions with, social work, let's say, have they been studied or they got degrees in social work as well as being police officers that we might be able to use? It sounds like a far out model, but it's something that someone has suggested to me, and I wanted to see if anybody was coming close to that. How about in Los Angeles? What, you guys have a model out there, right, Mark? Sorry if I caught you off guard. Mark Cohen, are you there? Or have I lost you by this point in time? Probably. Okay. Anyways, if you have, anybody else has something where maybe the police have been cross-trained with social work skills, or those kinds of, help handle some of these cases better without just being police taking them into some center, it would be someone that could work out dispos as well, and then yet have jurisdictional responsibility. That would be kind of cool. If anybody knows anything about that or like that, please let me know. Okay. Hey, so Eileen, you want to come on and give us a presentation? Are you okay with that?
I just got a call. Can I come back at the next round for me?
Yeah, like next week. Yeah, sure.
No. Just later on to just let somebody else go, and then I'll come.
Well, there's not much else. We're just going to go around the room. If you want to come back and do it, I just want to make sure you get it during peak period, because a lot of people are going to be dropping off here pretty soon. That's all, right? What were you going to present on?
You wanted me to talk about sugar toxin and
yeah. So that's an evergreen thing. Let's do that maybe next week then. Okay, does that sound okay? So
sure. I should tell you that I'm taking the auto train to Maryland on the 19th.
Okay, got it. Okay.
Yeah.
Okay, well, all right, we'll figure out. You go do your thing, and we'll maybe we'll see what time you get back. Okay, so thanks.
Okay, sure.
All right, let's pop.
Paul,
Yes.
Paul, could we return to the homelessness EMS abuse issue for about 2 minutes?
Sure, please do.
If that meets your calendar. Well, we're having an enormous problem here. I've got one alone that's over 200 visits this year. Was 3 yesterday, 29 this month. And this is a very, very clever person who is not without medical issues, but has got the system figured out that, you know, if this person leaves the hospital, we'll turn right around and go to this train spot, which will take him into Dallas's area. And then Dallas will then be called 911. So,
Yeah.
and so I tried to go to the hospital the last visit, which was 2 days ago, and just said, look, we just need to arrest this guy for theft of service. This
Yeah.
is hundreds of times. This is not dozens. It's huge.
Yeah.
It's vast. And doesn't seem to be much interest from the standpoint of the very higher ups to proceed with that. I'm not
Yeah,
criticizing
well,
anybody.
remember 10 years ago, we did that with the city manager. We actually started a program, and then I think it got kind of quashed by one of the EMS chiefs. But maybe that's something that has to go back, or or if I think there may be a new city manager coming in pretty soon. Maybe that's the place to do it. Let's you and I get together. And by the way, Linda and I would like to go out to dinner with you again sometime soon. Okay.
Deal. I'll bring the Thanksgiving gift that I did not bring on Thanksgiving. So
okay, got it. All right. Well, I'll call you after this or later this afternoon. So I don't know if you were on. Were you on before when we announced that Michael just had 2 kids, right? 2 girls. Yeah,
so
the twin girls were delivered today. I'll send you. I'll text you a picture. Okay, so great. All right. So Ray, of course, has been such a dear friend, and just a great advocate for our kids all along. We just it's part of our family. So it's just I wanted to make sure he knew about that right away. So that happened overnight last night.
that's wonderful.
Okay, good. So let's quickly go around the room. Did I lose Mark then altogether? Okay, okay. So is Ben's iPhone, is that or BI, Ben's iPhone? Yeah. So is that out of Baltimore? Is that you, Ben, in Baltimore? Which Ben is this? Or is it Ben from Ben Weston, maybe in the ER? I don't know if it is. Could be. All right. So we'll skip that one then. So I think Ben Weston's working in the emergency department today. So I just wanted to see if he could talk. If not, whatever. Angus, anything out of the state of Florida? I'm just going to kind of go down the list real quick.
No, nothing else, Paul. Thanks.
Okay, good. And Angus, for those who don't know, is our state medical director there, let alone our county medical director in Pinellas and so on, and always at the cutting edge. Love it. Julian, anything to report from your end, by the way?
No, nothing relevant to report at all. I'm just kind of in a holding pattern for 220 days until I start my first day of school.
All right, got it.
All
Hey,
right.
yeah, it's so cool for him, right? So, hey, I was going to say, and Julian, then thank you. You're going to still be hosting this as you're doing. So I really appreciate you doing that. And it's fantastic. And if we can, I try to remind me, maybe next week would be a good time, or the week after, to do a memory of the person who we were doing this in honor of, who started these seminars in the first place. Specifically Dr. Manifold, and I'll give you some time to prepare some thoughts and words about him, and not only in general, but also your own personal relationship with him. I'd like that. I think I want to continue I purposely don't say the memorial lecture. I always say it's his lecture, because he's always with us in spirit. He was a true muse for me, and sometimes gave me advice that I'd go, which surprised me coming from him, because he was such a kind and generous person. And sometimes he really was just fantastic. So thank you so much. Just like Dr. Fowler here. Okay. Terry, speaking of some of our elders, right? Our church elders. Anything to report on Tucson, Terry?
No, it's remarkably quiet here.
Okay.
Thankfully.
All right, good. They got new ambulances there. Is that true?
Yeah, pretty spiffy.
Okay. Well, why are they spiffy, or anything or particular that makes them spiffy?
Some Lucas devices being thrown around.
Okay. All right. Well, let's go down. Bill, anything? Are you up in Lake Tahoe today? Bill Bomber?
Yeah. Can you hear me?
Yes, sir. Can sir. Anything to report out of California?
Snow is up here, so skiing has started. We've got we're getting another 1.5 feet of snow tonight, so we should be all set. And there is basically no homelessness in Tahoe
in Mount Rose,
area.
No homelessness at Mount Rose, right?
Correct.
Hey, we'd be happy to send a few up your way to make you feel warm and fuzzy.
You know,
So,
if you mentioned homelessness, our biggest is in LA County,
right.
that we have it. Sacramento has more than San Francisco, but LA and New York are the two biggest areas. But I looked at South Dakota, North Dakota, and Wyoming have less than 1,000 homeless. So I think
In the
weather
state,
does
in the state.
in the state, in the whole state,
Wow.
have much less than we have in one small section of Sacramento. So it certainly is it is climate related at some extent.
Okay. So no one's hanging out at Rayleigh's, huh? They're asking for money. Okay.
Nope, there was one homeless person here earlier in the year, but no longer here.
Hey, where was Jeremy Renner living? Was he out near Mount Rose or near where you are?
So he's just around the corner. He's on Route 431. That's the road between Incline Village and that goes up over Mount Rose. So he was on our side of it and still lives there. Obviously, still has his home there. Just the the problem was messing around with a large snow vehicle that he probably wasn't experienced in running.
Yeah. Well, he's looking good and doing well. So I thought he lived out there on that way. That's what I was asking. So okay, cool. Well, listen, all right. Well, thank you so much, Bill. AJ, anything you could give us? I'm just gonna go down the list here as I'm looking at it. So everybody could be prepared. Okay. AJ, anything for us today?
No, Paul, thank you.
Thanks a lot. Eileen, I guess, was off for a while, I guess. Let me go down. Ben's in the emergency department, can't talk. Eric, anything new to report from your end?
No, we just continue to hope to get closer. We're at like 196. I was hoping to be at 200 by the end of the year. So
okay, got it. Thanks, Glenn.
Yeah, they just acquitted the chokehold Marine of our homeless guy on the subway. So we thought there's going to be a lot more protests and such. So far, knock wood, it's been pretty calm. And as you know, the shooter in Manhattan was caught in I think Altoona, Pennsylvania. So that was big news for us as well. Other than that, we're waiting for protests, but luckily we're on standby.
Yeah. So it's interesting because there are already some signs of copycats, that or at least people threatening to be copycats of what he did. Hey, Ray, I don't know if you know this, but the alleged perpetrator for the killing of the United Healthcare CEO, his sister is actually a resident with us in internal medicine at Parkland. Were you aware of that? Yeah.
No.
Wow.
That's a lot of pressure on her. My
I
God.
know. God, is that right? So I just thought, I didn't know if you're aware of that. I don't know if it got out there yet or not, but it's probably gonna be out there.
And I've been trying to keep up with him, reading about that.
Okay, well, at the event, she has the same last name, so you could find that out probably pretty quickly. But on the other hand, you're right. You don't want to put any pressure on her or anything like that. All right, let's flip over to Denver. Anything to report, Jacob?
No, I actually just put in the chat that I have to hop off for another meeting, but nothing major. Thanks for those taking the time to fill out the survey. I think that went out for Shay and I, and hope to see you next week. If not, happy holidays to everyone.
Remind us about the survey and what you found.
It is essentially I think it just went out yesterday, so it's just asking around response time stuff, and then we'll certainly report back.
Yeah. Okay. Good. Okay. So it just went out. We didn't get and then part of the deal there, as far as we're concerned, because I mean, you're relatively new to us, is that once you get it, then you come back and assimilate it and give us a report on it. Okay. So we could have that to be kind of good. Okay. So
absolutely. Yeah. Shay and I'll connect and we'll put something together.
Okay, good. Jeff Goodlow, anything reported out of Tulsa or OKC?
Just the usual chaos of medical dysfunction, at least in the community.
Yeah,
we're providing very organized response to medical dysfunction, but we're operationalizing our video laryngoscopy system in the next 2-3 weeks. So we're excited about that. That may be something I report on at Eagles next summer. We'll see how the early part of that goes. Everything's still going fantastic in the tiering of the system here. We're, I don't know, 80,000 something eligible calls for BLS response, and things are humming along very nicely there. So a lot of good stuff. Peter will be happy to know that we're expanding whole blood to pediatrics. So that is in the move. And I think that's just a great example of sort of stair-stepping your way into a program. We all want to solve everything immediately, but sometimes it's a little better to walk and then run and pick up some friends along the way.
Cool. Okay, good. Hey, I just want you to know, I want to give you some feedback. I talked to the general manager at the Hyatt Regency in Tulsa yesterday and thought you were like incredibly amazing person. And so I straightened him out. I just want you to know. No, he had great things to say and was so grateful for hooking up with you. So, okay. So thank you.
Paul
Jeff,
came to visit and in usual Pepe style, pretty much owned the town and let me rent it for a few days. And so, although I was disappointed, we didn't have any A-list rock stars in town other than yourself when you were here.
Right.
So,
I got to tell you, I have a new introduction for you. You're going to love this. I'm not going to tell you right now, but I have a new introduction for you that you'll be impressed by. You'll see when the time is right. I have to do a few more things first. Okay.
I already know Jelly Roll though, but that's okay. I'll be happy to talk to him again.
Hey, Paul, a word for Jeff. Jeff, Kathy Renard is finally stepping down after all these years. You started it, and
I started her stepping down. I drove her that crazy. I mean,
yeah.
Well,
that's 25 years.
It's always good when you can outlast your fellowship director, right? That's a good sign you've got career longevity.
But I know you'd want to drop her a note or something.
Yeah, absolutely.
So Jeff was our first EMS fellow at UT Southwestern Parkland. And so just
was that 30 years ago, Joe?
I don't know. It feels like 30 years ago. It's like 20, probably 25.
Yeah, 25. It was quarter centuries. That's
somehow the program has still survived. It's amazing.
And we've chosen our one for the future already. So we're keeping rolling.
Awesome.
Let's go down to Joe. Let's go to Joe Holly. It looks like popped in here on my list here as I went down here. So Joe, anything to report out of either the state of Tennessee as your director there or Memphis?
No, I don't know that there's anything really significant going on. We did have our state board meeting last week, and move forward on formalizing some paramedic scope of practice issues and system scope of practice issues like blood administration and all that. Tennessee's approach to that has been sort of pilot project ideas, and I think we're past that now. So we've got that in place so we can start moving ahead much more aggressively now.
Well, let's go a little further north to Joe Salkin and give us a shameless plug, Joe.
Thank you, Dr. Pepe. We're having our end of the year North Carolina EMS Blood Coalition meeting next Thursday. The link is in the chat. We're diversifying who's presenting. We're trying to bring our blood bankers in to have a discussion on what it's like to work with a blood bank in establishing a pre-hospital blood program. So we're ending up the year pretty good. Looking forward to having it.
Fantastic then. Okay, good. Hey, Libby Char, anything to report out of Hawaii or Honolulu or anything that you could tell us?
We're still looking for EMS branch chief for the state. So if anybody's interested in moving out to Hawaii, it's primarily an admin job, all that fun stuff. But we are looking for somebody. And oh, by the way, it pays really horribly. So anybody interested, give me a holler.
And the cost of living is so low there, maybe it's okay then, right?
Yeah, but you can spend a lot of time outdoors.
Yeah.
But anybody interested or know of anybody who may be interested, please drop me a note.
What is the job again? That's so funny.
It is the state. We have a statewide EMS system, and this is the state EMS branch chief. So essentially, it's a person that would run state EMS, but
it's not necessarily a physician. It's it could be administrator.
Right now, it's a physician position, which I think is a mistake. It used to be an administrator, and then there was a side, for the clinical for the state EMS medical director.
Yeah.
And a couple of people ago, it got combined into one because that person said that they could do both. And so it got combined into one position, and it's really, really hard to find a physician administrator, especially for a state system, all the rules and regs and all that. But so we're trying to split it again. I hope that goes through, but it's kind of a chicken and the egg thing. You need somebody in that position first to then advocate for splitting it back apart.
Okay, so at least for now, it is a physician position that we need.
For now, it is a physician administrator position.
That helps. That's it. Okay, good. I wanted to get that clarified. All right, fantastic. Okay, and it's great to see you, Libby, as always, as usual. Do you have a state income tax there as well, by the way?
Yes.
Okay, yeah. There's several states that don't. That's why I was asking about that. Okay. Then let's go on down to Joe, Libby, Mick. How about Dublin? What's happening and throughout Ireland as well, or anything you can tell us about the Euro-based systems, right?
I'm very interested in that last phrase that some places don't have state income tax. So I've never heard of that. So that's a place I'm looking to move to fairly soon.
Well, you're going to either
come on down to Florida, Mick.
Yeah.
Really? Wow.
There are political implications.
Where have you been?
Florida and Texas, right? Are the two that come to mind right away.
Why do you think none of us live in New York anymore?
Wow. Okay, well, the only news I have is the National Non-Kicking Ball League are coming to Dublin next year. The Pittsburgh Steelers are playing a game in Dublin. So
I guess, do you know who they're playing?
No, not yet. I think it's Chicago.
Oh, okay, got it. Okay, that's interesting then. All right, good. And then what time of year will that be? Do you know, in early September, October, or when do you think?
No idea yet. No
What
idea.
stadium are they going to play out of?
I think it'll be Croke Park. So Goodell was over here last week, and he announced Berlin. They thought he was going to announce Dublin at the same time, but he said there are 3 more games they're going to announce in the next coming weeks, and I think Dublin is pretty much in one of those. We had a group of physicians going through plans recently, so I think all that they're happy with the medical security part.
Yeah. Well, you have a good system over there, Croke Park. I like it. And the other thing that's very interesting is that is how they don't have one single choke point where people are coming in. You, based on their ticket, they'll go to different streets or different entrances, etc. And I think that's helped with traffic. Is that true? They're just a really good setup.
It's good for traffic. It's good for getting people out afterwards because there's not a lot of mass transit close by. The trains are a couple of miles away.
Right.
So it's good for getting people in and out, but they also try and keep people around those stadiums for longer. You have your tailgating and big car parks. None of the stadiums here have car parks attached to them. So you're trying to get people in, and they kind of stay in the environs, hotels, bars, close to the stadium. So it'll be a big day. It'll be very exciting.
Hey, remind me, what's the, go ahead. I'm sorry to interrupt you.
The one tricky part we have is just because there's so many players, it does take from the bottom few rows of seats because they just can't see anything. You've got these walls of monsters standing in front of them, so they can't really see the game very well. So they have to block off, I don't know, I think it's 5 rows of seats to be able to see the game.
Well, they should set up a Garth Brooks stage and have them up there. So, all right. Well, listen, Mick, remember the thing? I can't remember. It's called 3 words or 3 whatever.
What 3 words?
Yeah.
3 words?
Yeah. What 3 words? I heard a great presentation today from Washington, D.C., their blood program, and they track where their supervisors are who have the blood, and they're using those kinds of things for, to GPS people in fast and quickly and find out where the closest available blood is. Peter, can you comment on that? Because you're very familiar with their system there, right? Are you there still?
Yeah,
Peter?
well, yeah, I'm here. Thanks, Paul. Yeah, they use ArcGIS, which apparently many states and governments have that ability to use that software, depending on what level of software you have. But they then use APIs to connect all the information into ArcGIS. So they have a dashboard that gives them the location, the temperature, the age of the blood, so that they can easily see where the blood is that's the oldest, and they're able to cycle that blood across safely and easily. So very, very high tech, very well done. And I think that all the larger kind of tier 1 cities, if you will probably end up needing something like that, because when you're giving that many units of blood a year, and the logistics behind it are that challenging, you probably need some automation behind it.
And so the thing that I specifically brought up was that they use the, what 3 words thing to locate. Like, what is it with, you could find someone within what, 3 meters?
3
or something
meters.
like that? Yeah.
3 meters squared, using just 3 words. So if you would ask a random person to give you their GPS coordinates, because there's so many digits, it's complicated and people can get the number or the numbers wrong or misread the numbers, and then you're miles away. But with just spelling 3 words, you can locate anybody within a 3 meter square anywhere in the world.
So they're using that, Peter. They're in DC. It caught my attention, and so I wanted everybody just, if you're got a program or think about that and find out what DC is doing, and then think about that. But that concept's great for mass gatherings. Period. That's where we first use it in the first place. So
for tents and stuff. There was one significant EMS thing here in the last couple of weeks. We have a food company which are now using drones to deliver fast food.
Yeah.
And because they're not busy all the time, they started doing a trial for the EMS on delivering defibrillators to cardiac arrests.
Okay.
And it's become very successful. So it looks like they're going to go into a partnership with the ambulance service. We have these community first responders who, one of the 4 people will have a defib, not everybody. So if one of the other partners arrives at the scene, they may not have access to a defib. This food company is going to start delivering by drone defibrillators in these localities, and that looks like it's going to be quite a successful initiative.
When you say success, in other words, they get them there, or you had people who got saved when they used it? Oh, wow. Cool. That's reportable. I want to hear about that. So, all right, let's run down the list real quickly because we only got a couple of minutes left. Rob Dunn, anything out of Detroit that we need to know about?
Yeah, 10 degrees in the morning, second day in a row, getting everybody's getting their cold on. We got our shelters open for warming, and we've had some cold casualties, and of course the inevitable carbon monoxide poisoning that goes with the cold days. Getting ready for some of our holiday special events, and
yeah, and then also
not too crazy.
People get creative with how they heat themselves. They get fires and all those kinds of things.
Oh yeah.
So it's good. All right. As we move down the list here, so we talked to Jeff, etc. So sorry, I'm trying to go through the list. Stein, tell us about Colorado Springs. Anything to report out of there?
Nothing huge. We just ordered our UE scopes so that we're going to be phasing into those for video recording. And then also, Paul, I'll touch base with you offline, but need a little bit more information, but we may have some of the information about training police and putting police out there with social workers. And they go through specialty CIT training here with our behavioral health teams and with our homeless, what we call HOT teams, the HOT cops, homeless outreach teams. And so I can talk to you about that. Maybe it's worth a couple-minute presentation.
I love it. Okay, I want to hear about that. Okay, good. Yeah, remind me though, because I got so much stuff I got to get done in the next couple hours.
Sure thing.
That's good. Tom, anything on New Orleans? I saw your name right there below it.
Nope, we're still doing good. Just waiting for Super Bowl.
All right, Roger Stone, anything on Montgomery County?
Good afternoon, everybody. Yeah, so we had our presser yesterday at the 4-month mark of our whole blood. I gave a shout out to the Blood Transfusion Coalition that keeps the data. So I mentioned that in my remarks. And NBC4 Washington did a great job of trying to get all that in 2.5 minutes. The other thing is when I was hearing Dr. Fowler talk about this
Let me interrupt you for a second. When you said MDC Washington, what's that?
Yeah, NBC4 Washington, WRC-TV. That's the NBC affiliate.
NBC. I'm sorry,
they did a very good job. I'll throw it in the chat. The YouTube link to it is very good job. The nexus to that is I remember you were saying that I may deserve a jacket if I've survived 6 chiefs. Our chief just announced he's a paramedic. Our chief just announced he's going to try to get to NAMSP for 2 of the days to see the goings on. And then just another quick thought. Ray Fowler was
tell him to go to Eagles too.
Well, we're going to have our new ops battalion chief is coming along for that, along with our EMS chief will be coming with me for that. And then the other thing is Dr. Fowler mentioned the one very abusive frequent flyer. We have a frequent a high utilizer program. It was one of the first things our MIH tackled. And I was just curious as to if Dr. Fowler would let us know if that particular person was a failure of all the things that MIH and the jurisdiction has tried and just continues to be encourageable, because occasionally I'd be interested in how people handle that, because it is true the prosecutors put that the lowest on their list to try to do something about it, and it could be very, very difficult. So I'd be curious to see how other people handle those outliers after MIH may have failed.
Yeah.
But
yeah, and that's the thing, and it has been, and we actually had a program going for this about 10 years ago when I was there, with the city of Dallas, and I can maybe resurrect that and give you some things, but yeah, apparently it's long story, went astray. Okay, is there anybody I did not contact yet? I think it's time to wrap up, but and Eileen, if you're going to be on a train or whatever it was you're saying next week, we could always, this is an evergreen thing. I was just bringing it up because of all those food poisoning things that had come up, and during that period of time, that I just wanted to remind people about HUS.
Yeah, actually, there's 4 ongoing outbreaks right now. And I just needed a few minutes, but that's okay. I'll do it. Yes, I'm taking the auto train. If anybody has ever ridden it, Roger just sent me a really nice note. I love the auto train. I basically put my car in the train and I rented a room. So I have my own, it's like having a little hotel room, my bed, my desk, shower, toilet, everything. It's all mine. And they feed you breakfast, lunch, dinner, give you wine, and you end up on the other side without wear and tear to your car.
We kind of did that when I was younger, when I was like 5 or 6, and he took us something similar to that. It was someone asked me a question just now, because I want to go back to Eileen in a second. Go ahead.
Well,
yes.
Roger Ray Fowler, would you put your cell phone number in chat for me? I'm going to give you a buzz.
Mine? Sure.
No, Roger Stone.
This is about the homeless issue. He's going
about
back.
The homeless issue.
Yeah. Okay.
At your convenience.
So Eileen, we're actually out of time and we got to get going. But since you're on, and we'll ask you, so are you leaving Miami then? Is that what's happening?
Sort of. I'm going to have a foot in both places. I'm keeping my home here on Miami Beach. And I've already moved. About a third of my household is on its way to the new house in Maryland. And I'll be sort of going back and forth at least until April. Then I'm going to decide whether I just stay there or exactly what I do. But FIU needs me to continue working for them. So I'm sort of be working in both places for a while.
Yeah. So it's a new medical school they're building there. Where is it?
Brand new medical school in Hagerstown, Maryland, which is really in the middle of nowhere. It's very far from DC or even Baltimore. But it's fine. It's nice. My daughter and her family lives there, so that's fantastic. It's right on the border with Pennsylvania. And life is a lot less expensive there than it is here.
Yeah. I get it. Yeah.
Could I say something interesting? I have to admit being really embarrassed. The Meritus Medical Center replaced the Washington County Hospital, where I had privileges for 10 years of my career. And it was through Aileen's announcement last week that I'm like, what? And I'm looking at this thing that says 35 miles west of me that says First Medical School in Maryland for 100 years. And I'm like, egg in my face for not being on the cutting edge of knowing that like many months ago. So I'd love to hear more about that. Maybe Aileen could share with us about the medical school at a future Eagles, because it's really a hub in that shallow part of Western Maryland, and it's borders with West Virginia and Pennsylvania as well.
It goes back to that bumper sticker request that someone said he was going to have a bumper sticker made. I can't remember who it was, but he said it was going to say Eagles. You heard it here first. So there you go, Roger.
Yes. Egg in my face for sure.
Hey, Paul, I have a quick question for the group.
But I bet you it's over easy, Roger. The egg. All right. Okay, go ahead, Peter.
Yeah, so we just got a grant for the Siemens point of care test. And I had to get a CLIA lab thing. It's pretty much a disaster. But I'm wondering if anyone else out there is.
It's a point of care test for what?
So basically, it's a point of care test that provides, basically it's like a blood gas that gives you all the information a blood gas would. You get a lactate.
And it's not CLIA wave. It's not a CLIA wave test. You have to
No.
pass through CLIA. Let me tell you,
No,
I've been through that. It's a lot of work to get your CLIA clearance. You can do it, but you have to think like the military. Every dot has to be,
we're already,
dotted. Every T has to be crossed. Yeah.
Yeah, we're already 99% of the way there. Like we're not turning back. But I'm wondering if anyone has experience with it.
I do.
As
I have. Yeah, I set up an entire
in
CLIA
EMS.
lab. Well, I
No,
set
but as
it up
far
for
as
COVID.
in
It's the same idea. CLIA is CLIA. It's just a matter of your
No,
particular.
No, but I get the question I'm asking is like patient type. When are you using it? Is it for MIH patients? Is it for, your typical 911 run? I mean, our hospitals are so close, and I'm trying to figure out how to put together a protocol where we're actually going to have value rather than just time waste. It's not going to change my destination more than likely. The doctors may not care even of the results we're giving them. It may change treatment. I don't know, but I'm just trying to be sure that the juice is worth the squeeze. So Eric, I'll give you a call if Eric says he's done it. So yeah, Eileen, just to clarify, the whole CLIA thing we're going through is painful, but I'm wondering how people have rolled it out on the EMS side, if at all. So.
Okay.
That's the only Eric is
rolling. Let's get going. I got to get
Okay.
on. I'm going to double check one thing while I got everybody on, just for your own sakes, about the CME thing, because it was a reverse order. So I don't know if they changed that or did, because we used to be, the even numbers were Eagles and then the odd numbers were Seagulls. Okay. And so when I go now, I'm going to put in 19455 and I submit ID activity. I do get the Eagles with 1.50 hours. Let me put in 1.54, 54. And that was weird. It caught me by surprise. And by the way, I tried to do this last night, but their system was down last night. So it really kind of screwed me up on many accounts. It's not working very fast. Still not working today. There's something wrong with their system. And I actually invited the person who was in charge of it on. Let me go back here and I'm going to try it again. Let's see. No, I am not on the thing. Enter ID. Okay, 19454. And it says enter the ID number, which I did. Here we go. Yeah, here it is, 0.50. Yeah, so that's the one. That would be the 0.50 would be yours, Peter, the Seagulls. So just so you know, it's a kind of a reverse order. The even number of the 54 is now going along with Seagulls, and 55 was Eagles. Okay, so and that was put in by Jim Augustine earlier in the chat. If you want to look through that real quickly before we get off, 19455 for this one. Okay. Thanks, everybody. See you next week. Welcome back, my friends, and the show that never ends. And I think I'm going to slip down to a hospital and see a couple of young girls. Okay. So, all righty. So see you later, guys. Take care. Bye-bye.
Thank you. Bye.
Congrats, Paul, and congrats to Michael.
Yeah, congratulations.
Yes,
Yeah,
sir.
I'll pass on the congratulations. But it's an existential crisis when you say my son is a father.